Good morning, everyone. Welcome to this contact session of week 8. Today we have less time than every time, so I will try to wrap up within an hour. And both these topics, and this week's theme was not one topic actually. These are the two different topics: HIV-associated malignancies and HIV-associated dermatology. Both these topics are extensive if you go in depth of each one. Dermatology is something which in HIV especially, you might have seen many cases in your centers, and where there can be a lot of cases which can be discussed in dermatology, but we'll limit ourselves to NACO presentations this time. And also in malignancies is something which we don't see. I've not seen many cases diagnosed at ART centers, mainly because of poor diagnosing facilities we have, and also um, many of the times it happens that patients, when they get more sick, they usually don't come to the ART center. They may go to the departments like medicine department and other oncology departments and all that, but in ART center we don't tend to see many patients having malignancies. That's my personal opinion. You might have seen cases in your centers, but not as much as we should be able to see them. You might have seen these two lectures from Europe faculty, and where, especially in the session of malignancies, you might have heard that how malignancies are coming down with ART, especially those which are AIDS-defining malignancies, and other malignancies are going up. So with time, I think the key is to be more vigilant about diagnosing both dermatological manifestations, including in those which involve genital regions and all that. So clinical examinations and those things will be a key towards diagnosis. And also for malignancies, I think suspicion is the key. So we need to suspect, because sometimes what happens is we tend to treat TB, and obviously in our country, when we are doing clinical practice, we see TB cases more than any other case as a co-infection. And sometimes we tend to treat patients like for months together for an infection, not realizing that we have to revise our diagnosis sometimes if the patient is not responding. So malignancies usually are diagnosed after some time. So late diagnosis is not uncommon in our facilities, even though like I said, many of the cases we miss them and we don't tend to diagnose. The data on incidence of malignancies is like rare. It's very like limited as far as, especially in HIV positive population is concerned. There are a couple of studies which I'll show you in the presentation. Okay, so like every time, Shweta has involved all of us that the deadline of submission of quizzes, and also about the homework assignments. And this time, I think, thankfully, they have opened it for like you can submit your quizzes if you have not attended them before, which usually doesn't happen in UW, especially for quizzes. It is time bound, but as Shweta informed, now it is. Now also you can catch up with those quizzes which you missed in the past. So I don't know if they will be continuing with the same format, but if you have got the opportunity, I think you should solve the quizzes as soon as possible if you have not done already for the previous weeks. And this is the 8th week, and we have just 2 weeks left in the course. So let's try to complete it as much as we can. Okay, so let's start with malignancies first, and then in the second part we will talk about dermatology. As I said, I'll try to finish early this time because of the reason which I already mentioned, that many of the things you know about dermatology, and also for malignancies, we don't have much scope. Even if we suspect, usually we tend to refer these clients. So there is no point in going in details of treatment strategies of malignancies and all that. So I will not be discussing that part. So our focus is mainly to suspect a particular malignancy. So what should we thinking about, and which malignancies we should know about? And as a practitioner, I think you should know where to refer the patients if you see such cases or whenever you suspect any malignancy. So don't do that once the patient comes in front of you. You should be, I think, ready with your plans of referrals. So that is what is expected from this presentation actually. So in this part, we will be talking about the epidemiology, whatever is known about malignancies in HIV, and then which are HIV associated malignancies, or AIDS defining malignancies, or non-AIDS defining malignancies. So now these are the two things which you'll be reading everywhere whenever you try to read about HIV and AIDS. AIDS defining malignancies are those where once you see them, you can say that this is AIDS, and usually that is actually one of the presentations of HIV in many of the clients. So there are like malignancies like Kaposi sarcoma, cervical cancer, and also non-Hodgkin's lymphoma. These are called as age-defining malignancies, in presence of which we actually advise HIV testing. Others are called as HIV-associated malignancies. If you remember the lecture given by the UW faculty, they have also mentioned that the incidence of age-defining malignancies is coming down after this scaled up use of ART everywhere. But non-AIDS defining malignancies or HIV associated malignancies, those are going high because most of them are related to also aging, and because on ART HIV positives are surviving for longer time, and that is the reason the non-AIDS defining malignancies or HIV associated malignancies, you will be seeing more cases or increasing cases of those. So this was long back in 2000, where nearly 1/3 of deaths among French patients with HIV were attributed to cancer. 15% due to AIDS defining, 13% due to non-AIDS defining malignancies. So this kind of data, unfortunately, is not much from ART centers, at least. From ART centers, I don't know of any data um, about the prevalence of malignancies, and because of the obvious reasons that we don't tend to diagnose these malignancies because of whatever reasons, including lack of facilities. So in India now, what is known about it? Estimated that 3 to 4% of PLHIV in India have cancer during their course, compared to 34% in developed countries. And obviously their diagnosis of malignancies also is happening more than ours. Non-Hodgkin's lymphoma appears to be most common type of cancer reported in Indian PLHIVs. Now this is one study which was done by Dr. Dheer from Mumbai. So NHL, that is non-Hodgkin's lymphoma, constituted 30% of cancers seen in male and PLHIV, and 16% in female, because again in female cervical cancers are predominant or more common than non-Hodgkin's lymphoma. So now about this point, in the UW faculty lecture, you might have seen a detailed slides. At least there are 2 or 3 slides on this. Proportional incidence rates, that is increased proportional incidence rates, means HIV, how the HIV positive status makes a difference in increased incidence of these malignancies. So if someone has HIV, then there is more risk of developing these malignancies. So it was observed in non-Hodgkin's lymphoma, Hodgkin's lymphoma, like 17-fold and 4-fold increase in these malignancies if the person is HIV positive. In addition to this, in women, NHL was increased by 10 folds. And as I said in the UW faculty lecture, you will be seeing more and more evidence on this, that how much fold increase in these AIDS defining malignancies happen if the person is HIV positive. So it's most common cancer, HIV infected children, and proportional incidence rate was significantly increased. So it may be present cancer may be the presenting symptom of AIDS in children, and prognosis is again very poor if someone is diagnosed. Significant immune suppression was not commonly seen, and association with HIV with cancer among children must be kept in mind in pediatric age groups. So these are all AIDS-defining malignancies. Kaposi sarcoma, again, we'll discuss about Kaposi sarcoma later in the presentation, but we have seen very less cases. Maybe because we are not able to diagnose them. Obviously, it requires facilities like, again, sample collection and pathologists, mainly experienced pathologists. Again, anyone may not be able to diagnose it, so you need to have that kind of experience to diagnose all these malignancies. And non-Hodgkin's lymphoma, other lymphomas like primary CNS lymphoma or Burkitt's lymphoma, which is again one of the DDs of space-occupying lesion in the brain. Then Burkitt's lymphoma, which may happen because of Epstein-Barr virus, again it's a type of non-Hodgkin lymphoma. So especially in pediatrics, it is actually the fastest growing malignancies so if not treated in time, prognosis is really very bad. Then immunoblastic lymphomas, and then third is cervical cancer or invasive cervical carcinomas. These are the most these are called as AIDS-defining malignancies, which means if you see them, you need to advise HIV testing. And these have been included whenever we say stage of AIDS. If anyone has this, it is stage of AIDS or stage 4. The other are called as HIV associated cancers, and many of the times it is because of some virus as a oncogene or virus as a etiology. Burkitt's lymphoma, nasopharyngeal carcinoma, B-cell lymphoma, as I said, Epstein-Barr virus is the reason for that. Hepatocellular carcinoma, mostly it is because of Hep B, Hep C co-infection. Then cervical cancer, HPV is the causative organism, and that is why we actually have been asked to do pap smear, especially in the women above 40 years of age. But also it should be done for people who are MSM population, because in them again risk of anal cancer will be there. So pap smear will have to be, even in NACO guidelines you will see that it recommends doing pap smear, but again sample collection is okay, but you need a pathologist for making the diagnosis. So for MSM you can get pap smear for anal cancer. Is incidence of lymphomas and other malignancies high in PL-HIV than general population? Okay, so the answer is yes and no both. Yes, for those malignancies where, for example, if you see NHL, it is again high. Cervical carcinoma, it is high. Again, Kaposi sarcoma, it is high in HIV positives. So HIV positive status itself puts the patient at higher risk of developing these cancers. That is why we say that if the women PL-HIV more than 40 years of age, pap smears should be done annually to diagnose cervical cancer, because that is one of the most common reason of death because of cancer in women in HIV positives. So as I said, if you refer to the other presentations or UW faculty sessions, so he has actually given in great details about how many fold increased risk of malignancies in if a person is HIV positive, especially for age defining. So as primary prevention of cervical cancer in females, is HPV vaccine given? What's the Indian scenario? HPV vaccine is recommended. It should be given whenever it is possible. In program, it is program won't say no if someone is using that, but it's not being actually recommended like in those strong words. So I have not seen any strong recommendation for that. But yeah, you are right. If it is possible, it should be given. Okay, so other cancers like T cell leukemia, HTLV virus, Kaposi sarcoma is something which we will see in some time. So the HHV8 is the virus which is causative organism for that. Other like mesothelioma, non-Hodgkin's lymphoma, so Coady simian virus may be the causative organism. Merkel cell carcinoma, I don't know much about that. Then prostate cancer is again common, so one of the retrovirus is the cause of that. So risk of AIDS defining cancers in HIV positives. So Kaposi sarcoma, cervical cancer, non-Hodgkin's lymphoma. Here you can see the increased risk of these in HIV positives, and this is through this meta-analysis of 4,44,000 PL-HIV in resource-rich settings. So clearly there is a risk. Is more if someone is HIV positive than if the person is HIV negative. Now this is a case PL-HIV with CD432 and asymptomatic erythematous papillary lesions. I hope you remember papules are those raised lesions, and in this case these are colored, like dark colored lesions, mostly purple colored lesions. So freely mobile, non-tender, multiple lymph nodes over the skin and cervical area. This case is from Tambram, Chennai, like Government Hospital of Thoracic Medicine, Tambram, Chennai. Sputum, and this is the X-ray. Sputum AFB and FNAC of the lymph node was negative. CT abdomen, multiple lymph node at various places. Large, irregular, infiltrate, poorly differentiated lymphoid cells of medium size in the dermis, that is after the biopsy, and bone marrow study consistent of stage 4 NHL, non-Hodgkin's lymphoma. This is another case, 39 years old, HIV positive, was on ART. Again, whenever you see this, like mediastinal widening and all that, don't just think about TB every time. You can think of TB, you can start the treatment also, but if the person is not responding, please feel free to revise your diagnosis. So that is the point. And if there are associated lesions, I think the biopsy need to be taken from those lesions. And if you have facilities, you need to send them for investigation so that diagnosis is made as soon as possible. So, and again, TB is common, but whenever you have like huge pleural effusions or repeated pleural effusions, wide mediastinal widenings, and so think about malignancies. Always keep that in the back of your mind. Even if you diagnosed TB, even if you start patients on TB treatments, don't forget about malignancies there, and feel free to revise the diagnosis, especially in those cases where you don't get confirmation, like microbiological confirmation of TB, that is those which are CBNAT negative or CBNAT not done, and radiological diagnosis if you are treating those kinds of patients. Don't forget to review them after some time. Maybe after a month's time you may repeat the X-ray and see whether there is any regression or not. If there is further deterioration, don't hesitate in taking any other opinion. And in HIV positives, we have seen cases where there is a lymph node biopsy has shown granulomas and TB and all that, and patient was started on TB treatment. From the same lymph node, we were able to diagnose malignancies. So this is possible in HIV, like having infection and malignancies in one lymph node, that is possible. So don't hesitate in revising your diagnosis if that happens. Now this patient was on ART since August 2004. Baseline CD4 was 56 in 2006. Spontaneous fractures in left tibia and right radius, and CD4 was increased to 567. And here are the lesions in these are all pathological fractures. So biopsy from osteolytic lesions of right tibia, right high-grade NHL with plasmacytoid differentiation. These are all biopsy findings of these patients. Now this is another case study presenting as subcutaneous nodules. So again, biopsy is important in such cases. So now Kaposi sarcoma is one which is, I think it is related to HIV since the day HIV was diagnosed. In the last, I think one of the presentations we spoke about like how the HIV was diagnosed first, when pneumocystis carinii patients got admitted, and then when their blood was tested, it was HIV was found. Similarly, Kaposi sarcoma also, there were many cases which were actually admitted with Kaposi sarcoma, and that became one of the reasons for diagnosis of HIV at that time. So first described in 1872 in other population, but in HIV positives it was from 1981 it has been seen. So it is an age-defining malignancies which involves multi-system or multicentric. The causative organism, usually it is attributed to HHV8, that is human herpes virus 8. KS primarily affects the skin mucosa, mucoskeletal lesions are rare, but they may also occur, mostly combined with aggressive cutaneous or mucosal KS lesions. So it is rare in India, but Manipur has reported quite a number of cases. But like I said again, many of the cases might be going unnoticed. I had seen, I think, only 2 cases till now. One was in Bel Air in Panchgani, another was in Tambram. But again, as I said, a lot of it depends on both the cases could not survive, both the patients could not survive. But many of the times it depends on again strong clinical suspicion and strong support from the lab for diagnosis of this type of malignancies. Again, it is purple lesions you can see in the palate, over the skin, dark colored purple lesions. This was from JJ Mumbai. So this is for correlation between HIV and cervical cancer, and this is in relation to ART or impact of ART. So when the ART coverage is increasing, the incidence of regression is also increasing. This is about cervical cancer, CA cervix. Non-AIDS defining malignancies, again there is a list of it: multiple myelomas, anal cancer, Hodgkin's disease, GI malignancies, lung cancers, breast cancers. So all these malignancies, as I said, the incidence is going up, not because of HIV, but because of longer survival of HIV positives, so that we are able to now diagnose more and more such cancers in these patients. So these are like potentially HIV related immunologic mechanisms. Again, to some malignancies, HIV may be a contributing factor, but many of the times it is not related to HIV directly. This is another case, a 36-year-old male weaver by occupation, HIV positive since 2004, was not on ART, approached the physician with complaints of breathlessness, cough, expectorations, first week of May 2006. Patient was apparently symptom-free 2 months back. There is no significant other past illness. Known smoker, alcoholic, diagnosed with pleural effusion now, and fluid is straw-colored, aspirated, was started on ATT and presumptive diagnosis of TB. Again, whenever this, usually in TB also you will see straw-colored pleural fluid. But moderate to severe kind of effusion, and especially if it is repeatedly getting filled, that is recurrent pleural effusion, is an indicator of adenocarcinoma or carcinogenic lesions. Complete hematology, renal function and blood sugar were normal. LFT was done, it was normal, and alkaline phosphatase was raised, and these were the CD4 counts of this patient in September and July 2006 and September 2000. June 2006 and September 2006. And this was the X-ray, as it was moderate to severe pleural effusion. ICD was inserted in this patient, because here you are seeing the mediastinal shift and again heart coming back to the normal position. But again, repeated accumulation of pleural fluid you can see here. So here there is no ICD. ICD was removed. Again, it was fluid came back. So pleural fluid cytology was done. Usually we do actually small sample is not sent, but a large amount of sample is sent, and after doing so that diagnosis can be done appropriately, because malignant cells are not easily found. So the large amount of samples is centrifuged actually to see if it is positive for malignant cells. So probably it is adenocarcinoma in this case, as the patient was smoker and all those things. Sorry. So this is another case, 36-year-old PLHIV on ART, zidodin, lamodin, efavirenz since 2006. Sputum was positive for pulmonary TB twice earlier, treated with CAT1, CAT2, and now being evaluated for pulmonary TB. Oral candidiasis, pan-digital clubbing, again indicates chronic illnesses. Also, it may be positive in malignancies. Uniform hard swelling is found in right scrotum. Testis is not separately palpable. Skin over the swelling is stretched. Testicular cord and sensations are absent. Left side testis and cord structures are normal. So this is testicular malignancies, and here you can see the secondaries in the lung, and also you may see secondaries here in the CT scan. This is CT abdomen. So USG abdomen and scrotum. So right testis is again larger in size than left testis. So it is increased. So it's a testicular tumor, and risk of seminoma is increased significantly in HIV positives. These are all other HIV associated malignancies like lung, liver, prostate, Kaposi's, causative organs, and what action can be taken. For example, the most common cancer in women in HIV is cervical cancer. So, and in men it can be anal cancer, especially in MSM. HPV can be the causative organism. That is why it is recommended that annual pap smear need to be done. Then treatment of dysplasias, if in situ cancers are diagnosed with surgery, antivirals or cryotherapy. Smoking cessation or ART may help, but it is not proved. Then lung smoking cessation, again ART may help. Liver treatment of HBV, HCV should be done as soon as they are diagnosed. If untreated HBV, HCV infection may land up in this where you may require liver transplantation in some cases and of cirrhosis. Then prostate, HHV8 query causative organism. Again, all these strategies may help. So, increasing survival of HIV infected patients may predispose to an epidemic of malignancies among long-term survivors. So, as I said, again, age-defining malignancies may go down, but as HIV-associated malignancies, you may see more and more. Especially people in Northeast should be able to diagnose HBV, HCV co-infection as soon as possible. And people in other places also, whenever there is an IDU HCV diagnosis should be made and should be treated. Otherwise, again, malignancies, liver malignancies is one of the ultimate reasons or complication of these infections. Then ART use may be associated with decline in some, but not all malignancies in PLHIV. Effective screening and prevention measures have to be defined for non-age defining malignancies. But as I said, again, linkages is one more crucial screening, prevention, for diagnosis and confirmation and treatment. You need to have good linkages with cancer treating institutes, or at least if you have specialists in your own hospitals. So those need to be well identified before time. So I think that is what is like an introductory session for malignancies in HIV. Now we'll see dermatological manifestation in HIV. We had also discussed that in brief some time back when we discussed clinical staging and all that. So in dermatological manifestations, the lecture which was taken by UW faculty was very interesting. So he said these 8 recurrent themes, and on each theme the presenter he gave some examples. So I think it is worthwhile going through those 2 lectures of UW faculty because those were very interesting. I'll just read out these themes for you. That skin is next to blood and lymphatic. Skin is in HIV is most commonly affected organism organ. So skin is considered to be an organ, just not just a barrier for damages from the external environment. So it is an organ and it has many things like many layers, and also all these immune cells, and is actually main protective barrier from the outside infections. So, but again, it is most commonly affected. That is why we should know about all these at least common lesions seen in the skin. The skin can help stage HIV infection, like we had discussed during WHO clinical staging. Wherever we see, like, for example, herpes simplex, we put that in WHO clinical stage 2 of HIV. Skin problem can be the first time of sign of HIV infection. Many HIV-related skin conditions are inflammatory and non-infectious. Skin is an immune organ. Many conditions improve with ART, and there is no specific treatment for many conditions. If you just start ART treatment, conditions will improve. Then multiple skin conditions in the same patients at the same time is common in HIV infection. So as I said before, we need to always suspect multiple infections which can be seen. So as I said, all these 8 themes, there are examples on this in the UW faculty presentation, and also he has shown some acronyms just to remember what kind of skin infections happen. So importance of skin examination in HIV. Again, just before that, to diagnose that properly, a few recommendations were there in UW faculty session. One was you should have a good light, maybe natural light if possible, but if not, then a good illuminated room should be there. The lesion should be carefully seen. Skin should be exposed properly, especially in genital regions. Many of the patients are shy, and also our providers are most of the time shy in looking at the genitalia, especially if they are complaining for something. So I think as a practitioner, you have to document all those findings if there are any lesions as such. So especially new patients in detailed examinations, you should be also examining for STIs and genital lesions. So another recommendation was, like, you should be carrying at least that 4x lens, the simple magnifying glasses, so that we can easily see. Now these are the things which we need to keep these things handy in our ART clinic, and if at all you are interested, you can learn how to do KOH mounting and all that to diagnose fungal infections and all. So these are the few things which are required for examination. But what is the importance of examination? Because skin can be a portal for opportunistic infections. It indicates underlying systemic conditions. Sometimes, for example, TB, and it has sinus burst on the skin, you will be able to diagnose TB because of that. Then indicator of immune system function, indicator of drug reactions, like in Steven-Johnson's or toxic epidermal necrolysis. Then recognition of certain skin-related iris after initiation of ART. So in early immunodeficiency, in skin disorders are like common, recurrent, self-healing and clinically indistinguishable, but in advanced immunodeficiency, these are persistent, painful, progressive, atypical and non-healing. This is again the same graph which we had seen before, like with a drop of CD4, OIs come in, and many of the OIs you will see, like scabies you can see anywhere, but Norwegian type of scabies, which is like a involvement of like greater involvement because of scabies. You will see here the CD4 count is less than 200. Kaposi sarcoma and other malignancies you will see again here. But other common infections like tinea, seborrheic dermatitis, which is nothing but dandruff, then bullous impedigos or skin infections, bacterial infections also they are common if the CD4 is high. So these are the cutaneous disorders as indicators for HIV testing. Whenever you see any exanthem of seroconversion, like primary infections, then oral candidiasis, oral helicoplakia, recurrent herpes zoster, chronic herpetic ulcers, seborrheic dermatitis, pruritic papular eruptions. This is, I think, one of the most common things you may be seeing, which is non-infectious. Patients will have severe itching, or whatever you give, it won't go. Only after initiation of ART, after some time, it may go off. So at this time, again, treating patients symptomatically will be important. Just to keep the patients comfortable on ERT. Multiple molluscum contagiosum, again, huge molluscum lesions also you may see over the face and upper extremities commonly, STIs. Now this is acute retroviral syndrome. We had seen this picture before. That is immediately after acquiring infection, like any other viral illnesses, patients may show this. PP is stage 2, yes, it is stage 2. So exanthem, varying numbers of macular or maculopapular lesions. Actually, papular pruritic eruptions is not an opportunistic infection, but still you can keep that in stage 2. It is okay. Then associated ulcers in oral, genital, or anal mucosa. Skin histopathological examination can be done at this stage, but most of the times this condition goes unnoticed. This we had discussed previously also, oral candidiasis. On the dorsum of the tongue, you are seeing curd-like appearance of this lesion. Again, treatment is fluconazole 100 mg 7 days. Usually patients do well with fluconazole doses. OD. And this is on the lateral side of the tongue because of the Epstein-Barr virus. You can see these vertical margins, and this is oral hairy leukoplakia. There is no specific treatment for this. Just start ART. With ART, it will go off. This is again indicators of HIV testing. Recurrent herpes zoster. You can see one typical course of nerve which it is being followed. Herpes organisms or herpes viruses usually remain dormant in the skin, in the nerves, and whenever there is immune suppression, these infection again flares up. Typically, these are very painful vesicular lesions, and in the first 3 to 4 days, pain will be again really intolerable, and immediately after that, it usually subsides, but again sometimes it doesn't, and it continues to pain. And earlier the initiation of treatment is the better for the client. Treatment for herpes zoster is we give acyclovir in the dose of 800 milligrams 5 times a day. Sometimes the treatment has to be extended for weeks together, and it may heal with some kind of post herpetic neuralgia also, because of which patients will experience pain later in their life as well. So earlier initiation of treatment is better. Sometimes it may get co-infected with other bacterial infections also, where you need to give antibiotics in addition to antiviral drugs. This is again chronic herpes simplex, maybe HSV2, HSV1, HSV2. Usually HSV1, they say that affects the upper part of the body, but again it's not a rule. That's again general observation. This is from JJ Hospital, Mumbai, from Dr. Kura, who is actually head of the department in JJ. So he had shared this picture, these pictures. So again, to diagnose it early and treat it effectively, that is the key. For herpes simplex, again the treatment is acyclovir 200 milligrams 5 times a day. And sometimes it is also extended, especially in this case where it is so big. Seborrheic dermatitis. Okay, so chronic herpes simplex in stage 3 or stage 4. Herpes simplex is actually stage 2. Um, um, but again, disseminated herpes may go in stage 3, but I've not seen that in stage 4. You can check the list of stage 4 if you find herpes simplex in that. But disseminated infection usually go in stage 3 and stage 4 also. But generally, we put herpes simplex in stage 2. Seborrheic dermatitis, you can just please check the list of stage 4 if you can find herpes simplex there. Yeah. So this is again a fungal infection. You can treat that with fluconazole or ketoconazole ointments and all that also are available for dandruff. This is molluscum contagiosum. These are again umbilicated lesions or central umbilication, the raised lesions with central umbilication you can see. It can be treated surgically also with the skin treatments, but usually it goes off with ART. But for this kind of lesions, people prefer to go for surgical treatment, even in the beginning itself. These are pruritic papillary eruptions which I was talking about, and you can see all these scratch marks. These are papules, which is again not raised lesions, but these are like dots and dots. But the typical complaint is itching, severe itching. So you can treat the patient symptomatically. Okay, so in chronic herpes simplex, orolabialis, genital, anorectal of more than 1 month's duration or visceral at any site is clinical stage 4. Thank you, Dr. Dillon. So now again, this is STI. It is gonorrhea. Post-voidal, if you see this shiny secretions on the top of the urethral opening of the penis. And mucocutaneous manifestations in HIV infections, infectious, inflammatory, cutaneous, drug-drug reactions, neoplastic disorders, or immune restoration disease. These can be many. PP can be caused by ARV drugs. I don't think so. So it is not caused by ART, but in fact ART is a treatment for that. Usually once you start ART, once immunity goes up, slowly it gets better with ART. That's what I have seen. So again, there are some lesions, pyoderma, soft tissue infections. Now again, this is the region in axilla involving the underlying lymph nodes. This is nothing but a sinus which has bursted on the skin. So a patient was having TB lymph node, basically had a sinus, and this got burst over the skin. Here there is a patch where there is recently started on ART. 1 month after initiating ART, he came back to the ART center with well-defined erythematous lesion over knee, as shown in the figure. Actually, sensations also went down over this area, and it was diagnosed to have leprosy in this patient. Here you have at the angle of mouth, you are seeing all these infected lesions. So again, in this picture also you may see there can be various differentials for this. These are multiple warty lesions on both the arms. So these are like the DDs can be warts, giant molluscum or cutaneous TB, or deep fungal infections like chromoblastomycosis or histoplasmosis. So most common cause of these warts can be human papillomavirus. Now this is again another lesion. So this is a very commonly seen tinea lesion, actually tinea corporis. So usually the peripheral, that is the margins of this lesion, if you see, these are always like progressive margins and central clearing. So these are tinea lesions. Again, clotrimazole cream is used, or sometimes again it is combined with steroids as well, but usually it should be used, antifungal should be used separately. Warty umbilicated lesions can be seen in molluscum. I have seen the lesion as central lesions with central umbilication in like molluscum. Then you may see this also. This is again cutaneous lesion, which is involving the nail, especially nail bed. This is onychomycosis, fungal infection of the nail, and this can be again treated with fluconazole 150 milligram once a week. Also is given for this kind of lesion. This is again cutaneous lesion. Again, differentials can be molluscum contagiosum, but this is actually cutaneous cryptococcosis or cryptococcal infection. Again, this is a child where you are seeing central umbilicated papules. This is actually penicilliosis. This was, if you remember, we talked about penicilliosis or Penicillium marnefi in one of the sessions, and this case was from RIMS Imphal, where this Penicillium marnefi infection, that is penicillosis, were diagnosed. So these are really molluscum-like lesions with central umbilication. And this is again scabies, but it is called as Norwegian scabies, with involvement of the extremities. These are hyperpigmented papules and nodules with severe itching, especially between the digits, you can see. And the treatment involves topical permethrin benzyl benzoate with keratolytics, or oral ivermectin also is given. These are all good options for this. Again, but other than just giving medicines, other advices like washing of bedding and clothing and all those things are really important in scabies. Otherwise, it will come back. These are again papular pruritic eruptions. So psoriasis vulgaris and Rett syndrome and xerosis, these are inflammatory disorders in PLHIVs. Cutaneous drug reactions, we had seen like pruritus, urticaria, fixed drug eruptions, maculopapular eruptions, exfoliative dermatitis, Stevens-Johnson's, and toxic epidermal necrolysis. Difference between these two is again both are life-threatening. Stevens-Johnson syndrome is when it is actually the peeling off of epidermis. So the skin is directly or the person is directly exposed to dermis, and which is actually a burn-like phase. In SJS, it is involvement of the body surface area is less than 10%, but in toxic epidermal necrolysis, it is more than 30%. Management is very similar to the management of burn-like case, where the hydration is maintained. Sometimes it is very difficult to find veins in such patients, so oral rehydration fluid is given, and ointments are applied just to avoid the evaporation of the fluid from the body. And the offending agent is removed. That is the first thing which is to be done in case of any SJS. So every treatment is stopped, every systemic treatment is stopped, and patient is actually treated. So nursing care is the most important thing in management of SJS and TEN, toxic epidermal necrolysis. This is again purple colored lesion of Kaposi sarcoma. Again, the Suspicion is the key here in all these cases. So we need to suspect for any malignancies, including corpus sarcoma. So for that, actually, we need detailed examinations. So imagine in a busy center, the way most of us do, even for the new patients, we are not able to give proper time. So diagnosing any lesion like this is next to impossible if we do the examination like in say 2 to 5 minutes. So we should be actually giving more and more time, and once you diagnose that in time, you can save your patients. So clinical examination is the key, which I think slowly our centers are losing track on that. We are just becoming like more and more center for dispensation of medicines, because that is our main caseload, and we want to do that, which is good actually. But for our clinical examination and those things, we should never be compromising on, whatever our caseload is. These are again lesions. We already saw these slides before. Now these are like comparison of molluscum contagiosum, cutaneous cryptococcosis, and penicilliosis. Similar looking lesions, but different diagnosis. These are all papules with central umbilications, or again presenting in a similar way. So other mucocutaneous infections. So mucocutaneous infections, they should be diagnosed and treated accordingly. So in skin, again, you may see many number of photographs and those case studies. I've limited just to like 35 slides for this. But it is very important. In fact, one of the most common infections you will see will be infection of the skin. And that is why I said you should keep those tools that will help you in diagnosing these infections. So more than 90% of HIV infected patients develop skin and mucous membrane lesions. No skin condition is specific to HIV. Identification of these infections can predict HIV presence, and persisting, recurring, chronic, severe resistant atypical lesions are common in PLHIVs. So we need to keep all these things in mind. Please explain about penicilliosis. Penicilliosis, again, I personally have not managed any case as such for penicilliosis, but I've seen some cases during my visit to Mizoram. Manipur, especially Rims Imphal. There we have seen some cases, which is not very uncommon for them. It is the causative organism is, as I said before, it is Penicillium marnefi. Mainly it is spread because of these bamboo rats, which is commonly used in that part of the country. Diagnosis is again based on this again biopsies and isolation of the organisms. For the treatment, we give injection amphotericin B for 2 to 3 weeks. So that is a treatment for penicilliosis, and again it goes on, like after that also maintenance therapy need to be given for that. That's what I think I've seen. I know about Penicillium marnefi, but personally I have not experienced managing Penicillium marnefi of my own. Can KS occur irrespective of HIV infection? Yes, it can occur. It can occur irrespective of HIV infection, but in HIV positive, the risk is much higher. Much higher, actually. Okay, so I think those were my slides for today. As I said, we are stopping early today. If you have any more questions, you can post in the groups. If you want to have some more discussions, you can please post your questions, and also you may answer for those questions also. So please feel free. But those who have not done the assignments, please do them as soon as possible. Okay, so if there are no more questions, then I think we can stop here. So thank you very much. Have a good weekend, and we'll see you